Good afternoon, everybody. So here are my disclosures. So many of us are aware that our patients know that prostate cancer diagnosis is flawed. Our patients know that the way prostate cancer is diagnosed is flawed. And how do they know? Because they read newspapers. This is the Daily Telegraph, the sort of thing that you guys might read, middle class paper. This is the Daily Mail. I wouldn't spend a penny to buy a newspaper like the Daily Mail. I might read it if it was given away free. But a lot of people read this, and look, it's all over the press. Now, we can't really answer many questions that our patients care about. Do I have cancer? Is it going to kill me? Do I have a tiger? Or is it a pussycat? Has my cancer come back? And how long do I have to live? Will I make it to my daughter's wedding? So when we think about the prostate cancer journey, what we have to realize is that there are many and changing needs for the patient as they travel down their journey. And today we're going to be talking about the diagnosis part of this journey. So when a patient presents with suspicious cancer, about half of them have a cancer. About half. It turns out that about a third of them have what's called a clinically significant cancer. This is the cancer that will kill them if you do not diagnose it. Okay, so then the question is, what is clinical significance? And clinical significance, it depends on how aggressive the cancer is, but it also depends on how long the patient's going to live. Okay, so a cancer in an 80-year-old may not be clinically significant, but in a 60-year-old could be, because they're going to live less long. That doesn't give us a handle on what type of cancer we should be diagnosing. And in fact, the volume is important. So this is a clinically significant cancer, and this one isn't. But nowadays, the ISUP, the International Society of Urological Pathology, has now said that we, me, and you, have to diagnose any Gleason pattern 3 or 4. Any Gleason pattern 4 or 5. So this is the new classification by the International Society of Urological Pathology. And essentially, ISUP group grade 1, which is what we used to call 3+3 cancer, is considered indolent cancer. Don't diagnose these cancers. Please don't diagnose these cancers. Because the chance of somebody dying from a cancer that's an ISUP 1 is like 3% over 20 years. On the other hand, all of these are considered clinically significant cancers. So anything that is an ISUP grade group 2 or higher is considered today to be a clinically significant cancer. What do your clinicians want, or what are they worried about? They want to find out what is the cause for a raised PSA. Is it malignant or is it benign? They want to reduce the number of biopsies in patients and the number of needles that they put into their patients. They want to decrease the number of insignificant cancers and increase the number of significant cancers. So how are they doing this? Well, all of you know that at the moment they use blind biopsies. 12 needles, 6 on each side, without regard to where the prostate cancer is. Except this should now change in 2019 because the EAU guidelines have just come out and said that every patient coming to a biopsy should have an MRI before biopsy. Every patient. But what that means is that in Europe, you should expect 1 million more scans per year. 1 million in Europe, 1 million in America. Now, what's the problem with the current methodology? The problem with the current methodology is that 30% of cancers are anterior and they get missed. 30% are anterior and they get missed. You could have a small cancer here that you would diagnose and call insignificant, and yet you have a bigger cancer somewhere else that you missed. That's a problem. You may actually hit the cancer with your needle, but the most aggressive part of the cancer you missed. So you can get misclassification. There are multiple problems with the way that it is done today. In 2019, we can do multi-parametric MRI and MRI-guided biopsy to address this clinical issue. You know the multi-parametric MRI consists of T2-weighted images, diffusion imaging, and dynamic contrast enhancement. We'll go through the details in a second. But we also have what are now called PI-RADS compliant reports. And we will talk about PI-RADS compliant reports, including diagrams that allow you to communicate to the urologist where the abnormality is. So for example, lesion 1 is here. It is 18 millimeters in size, and you can see there's a score for T2 diffusion and dynamic contrast enhancement and a PI-RADS score. A PI-RADS score. So what is a PI-RADS score? A PI-RADS score communicates with the urologist how likely it is that a lesion is significant for cancer. So a PI-RADS 5 is highly likely. Now you're going to say, what the hell is highly likely? Well, if you do the pathology, this is the results you'll get. So a PI-RADS 1 or 2, a negative MRI, will have clinically significant disease in 6% of cases. So if you call it normal, you will miss 6% of cancers. If you say this is a PI-RADS 5, I am very certain that this is cancer, it's only 72%. In other words, there's a lot of false positives in the community. PI-RADS 3, these are the problematic cases. Here, the clinically significant rate is 12%. 12 to 15% on average will have clinically significant disease. We now know that we've introduced PI-RADS 2.1. What is new in PI-RADS 2.1? Multiple things are new. The first thing we've done is we've introduced 2 new cancer types. One of these is called a central zone cancer. Most of you know that the central zone sits at the base of the prostate gland, right up at the top, above the transition zone, surrounds the ejaculatory duct, and then points downwards like a V-shaped, like a Versace necklace. Okay, like that. Central zone tumors are very rare. Central zone tumors are very rare. They occur at the base and they go and extend into the seminal vesicles very quickly. What is the central zone? Do you know what it is? A central zone is an atretic or atrophic seminal vesicle which you don't use. And we know that seminal vesicle cancers are rare. So here is a central zone tumor, right at the base, arising from the central zone and going into the seminal vesicles. Okay, so you should look for asymmetry on the high B value image, or DCE, and here is the DCE. And you can see here, I think the DCE was very useful in this particular instance. The other tumor that you will see quite often is the anterior fibromuscular stromal tumor. Tumor right at the very front. These have to be scored using transition zone criteria. not peripheral zone criteria. You have to use transition zone criteria. And here is a big lesion, and here is a smaller lesion. So here is an anterior fibromuscular stromal tumor just sitting there, and there it is on the axial image. Here it is on the ADC map. There, that's the B1000. Now you'll notice, very difficult to see on the B1000, but the calculated ultra-high B value shows it much better. That's why a ultra-high B value is now considered mandatory. So within 2.1, you have to do an ultra-high B value image, either acquired or calculated. This is now mandatory. So this is a change that's occurred. The last time we did PI-RADS, we forgot one zone. In fact, we forgot one zone on either side. So this zone here wasn't labeled. So that has changed. We've noticed. After 5 years, we noticed that 2 zones were missing. Okay, so now we have 41 sectors. Nobody uses these sectors. Nobody. But it's still there. Number 2, we've introduced the PI-RADS report, a template. So if you go to the ACR website, you can pick up a template report, and you can pick up the diagram. The diagram has changed because most men don't have a straight urethra. They usually have a urethra that's bent. So we've made a few subtle changes in the diagram. There have been some changes in the protocol also. So for example, for T2 weighted imaging, we say use at least 2 planes. At least 2 planes. Although many people are doing 3 planes. We've changed or relaxed this B0 value for diffusion imaging. Before it was B50 and higher. Now we say B0 is allowed. So, okay, so we have relaxed that. And the other thing is this mandatory ultra-high B value, mandatory, and the ADC must only use B values less than 1,000. For the ADC calculation, don't use all the B values. Otherwise, you cannot use what we were just hearing about, which is drawing regions of interest, because that B value change alone will alter that fact. So ADC must only use B values less than 1,000, and a 3D gradient echo sequence is preferred for the DCE, although you can use a 2D technique if you like. Measurements have changed. Measurements have changed. Axial, so transverse diameter is on the axial image. AP diameter is on the sagittal image. AP diameter is on the sagittal image. Right, so there we go, like that. What we couldn't arrive at a consensus on was, what do we do about the median lobe? Do we include it or do we exclude it? In the UK, we exclude it. In fact, we just measure the diameter of the median lobe. What happens if you don't get a sagittal image? Then how do you measure the AP diameter? Well, then you have to do it on the axial. Now, the transition zone is what's been causing the most problems. And here we have decided to give you more rules about how to use it. So basically, if it looks normal, don't score the transition zone. So don't score this, don't score that, don't score that. If it's typical BPH nodules, forget it. It's gone. Don't score it. So in version 2, you'll remember BPH nodules were scored as 2. Now they've been combined as normal or don't score. Okay? Instead, what we do now, we've introduced what's called an atypical nodule. An atypical nodule. Okay, so this is a typical nodule. Right? All of you recognize it. Well circumscribed, A typical nodule is a typical nodule, call it 1 or don't score it. Okay? Here's another typical nodule. In this particular instance, you can see there it is, hyperintense with a low ADC value. Now, what is a 2? What is a 2? A 2 is a band-like area between nodules, a band-like area between nodules. So, here is a band-like area between two nodules. It must not be hyperintense on the ultra-high B value. It must not be hyperintense. It can be lower in ADC, but it mustn't be high. That is a 2. Here's an example of another 2, and this is benign because here it is in 2013, here it is in 14, here it is in 16, here it is in 19. 5 years, no change. The other thing that is a 2 is an atypical nodule. An atypical nodule. What is an atypical nodule? An atypical nodule is a nodule that doesn't have a capsule, or it has an incomplete capsule. No capsule or incomplete capsule. For those nodules, look at the T2 and ADC. Look at the ADC. Okay, so if you have atypical nodules, here's no capsule, incomplete capsule. If it's hyperintense on high B value image and dark on an ADC, it gets promoted to 3. Right, so if it looks atypical but it's got bright dark, then promote it to a 3. So that is a big change, and that becomes a 3 now. So let me show you an example. So this is not a completely circumscribed nodule, so an atypical nodule, right? Dark here, but not hyperintense. Not hyperintense. This stays as a 2. This is different. This is not a very well circumscribed nodule, but you see it's hyperintense and dark on an ADC, so this goes up to 3. Now what this means is that you will be biopsying more transition zone lesions. And we've done that deliberately because we are missing transition zone carcinomas. The literature shows that we are missing transition zone cancers. So we need to pull that back. We need to increase the sensitivity. So this is an atypical nodule, which is a 3. And look at it, 2013, 2017, 2018, and 2019, it doesn't change at all. Can you see? Over 5 years, ADC stays low over 5 years. However, you'll notice here that there is a growing cancer. Can you see over that? Go back to 2013, and you see how it changes over time. So there is, in fact, a growing cancer in the peripheral zone. This patient is on active surveillance, but the atypical nodule does not change over time. So that's a 3. Here is the summary. A 2 is a nodule that we described as a band-like area or an atypical nodule. If it's diffusion positive, then it goes into a 3. Nothing else in the transition zone has changed. Nothing else has changed. Okay. And so if you look at what we used to have before on the diffusion imaging, this low signal change here and here, either bilateral symmetric or asymmetric, this is now gone. It's gone. Okay? That's a problem. It's a problem if you don't have an ultra-high B value. If you have an ultra-high B value, you get that back. So for example, here is that kind of low signal change. It's difficult. This would be a PI-RADS 3. Here it is on a B1000, here it is on the ADC. This, in the old days, we would have called that PI-RADS 3. But you put in an ultra-high B value, then you see this dot. That dot enhances. This is a PI-RADS 4. Right, so that's why we made the ultra high B value mandatory. The definition of 3 has now changed. Okay, so this is a typical PI-RADS 3 lesion. Here it is on the T2. You can see that it isn't bright on a B900, but it is dark on an ADC. Now, this would have been classified before as a PI-RADS 3, but because it enhances, it's now a PI-RADS 4. So the rule has not changed. So focal, discrete, different from the background, hypo-intense on ADC, or focal hyper-intense on high B value, but not both. That's the important thing. These are the people with contrast will go up. So there's a subtle change in the rule for PI-RADS version 3, for the diffusion sequence category 3. Now many of you will say, do I have to give contrast? It's a headache to give contrast. I need to be there, it's expensive, it takes time. Oh, God. You know, this discussion goes for forever and ever and ever. We discuss this. And there are good reasons why you shouldn't use contrast. People point to data like this. They say, you know what, biparametric, multiparametric, the sensitivity, specificity is the same. I don't need to give contrast. Actually, that's rubbish. Because all you're doing is you're pooling lots of data and saying, I can't find a difference of 5%. If you start looking at individual studies and you look at patients and what percentage it starts helping, then you begin to see differences. So these are paired studies showing before and after, before and after, before and after, etc., etc. Then you do see that there are changes. But I agree, in the percentage-wise it helps you is very small. It's 5, maybe 7%. But the interesting thing is, if you do biparametric MRI, the number of PI-RADS 3 will increase. And here's recently published data showing that you can see PI-RADS 3 started off at 40 cases with a multiparametric MRI. You go to biparametric MRI, you're up to 70. Hang on a minute. PI-RADS 3 went from 40 cases. If you do a biparametric MRI, it goes up to 70. So you've almost got a 75-80% increase in the number of PI-RADS 3 cases. Hang on. Normally, PI-RADS 3 cases would be about 20%. If that increases by 70-80%, that goes up to 1/3 of cases. You see what I mean? So you might be quite good with a multiparametric MRI, but once you go to biparametric MRI, you're going to be very bad. Right? So that is what you will give up. Now, if you are an expert center, right, let's say you're a super expert, you do more than 1,000 scans per year, then your PI-RADS 3 category is likely to be 5-6%. Then you increase by 70%, then you've only gone to 9%. So it's still very acceptable. But if you are at the top end, in terms of your reading, and say you are calling 20% of your cases PI-RADS 3, then you will go up to 30%. You become less useful. So contrast helps those people who are less expert. And of course, this is something we all recognize. So what does the PI-RADS committee say? The PI-RADS committee says nothing positive about gadolinium enhancement. It doesn't say use it for this, but it does say don't use it in these circumstances. So it says don't use it when you are very suspicious that there is a clinically significant cancer, family history, high biomarkers. A risk calculator says this patient is highly likely. Don't use it for that. If you had a previous negative MRI with a biparametric technique, the next time you must use multiparametric MRI. And it depends how good your scanner is, right? So look, this is a 10-year-old machine. This is a 4-year-old machine. This is 1.5, this is 3T. This is read by a radiologist in practice, and this is read by a specialist. This, right, was called PI-RADS 2. This is called PI-RADS 5 because there are 2 lesions here. You see, scanner, experience, age, quality of diffusion, all of that matters. Right? So if you've got a super duper scanner working optimally and you're reading more than 1,000 scans per year, okay. But be very careful with suboptimal imaging quality, because you will need the DCE to pull you out of a hole. What do you do when you have the result? 1, 2, 3, 4, 5. What do you do? Well, you should biopsy, okay? Who do you biopsy? 1, 2, 3, 4, 5. Well, at the moment we say the MRI pathway is 1 and 2, no biopsy. Your urologist will not agree with this, okay? If you say 3, 4, 5, you should do an MRI directed biopsy alone. Your urologist will not agree with you, right? So what they are interested in is this, right? They want to know what is the added value of MRI to their systematic biopsy. So it turns out if you add a MR targeted biopsy to everybody who is going to get a systematic biopsy, the value is 6%. 6%. Right? So if they do systematic biopsies and you add an MRI, they will get 6% more clinically significant cancers. On the other hand, if you just did this, no biopsies to the negative, and just did targeted biopsies for the positives, you will detect more cancers, right? And the value of systematic biopsy on this side is 4%. What we can say, and we can be very confident with high levels of evidence, that 1/3 of men can avoid a biopsy. 1/3 of men can avoid a biopsy. You can lower the rate of clinically insignificant disease by about 40%. You can increase the detection of clinically significant cancers, particularly in patients who have had a prior negative biopsy. What this is saying to you is that there are some very high level evidence showing the value of MRI and MRI guided biopsies, and there is now a pathway, it's called the MR biopsy pathway, where patients can go down different routes so that they can get their treatments. And you know what? Not only will you say this, but your urologists will also agree with you now. They have to agree. Because the EAU 2019 says, adhere to PI-RADS guidelines for acquisition and interpretation. When MRI is positive, i.e. PI-RADS greater than 3, right, combine a systematic and targeted biopsy. So they still want to do systematic and targeted biopsy, right? When MRI is positive in somebody who's prior negative, perform only targeted biopsies. So they are coming with us, but they are not completely there. So these are now the 2019 guidelines. So these are my take-home points. The important thing to remember is that the PI-RADS system is a rules-based system. You see this, you call it like this. Okay? It's a rule-based system. It's meant for multiparametric and biparametric MRI. It does indicate the likelihood of clinically significant cancers. So the higher the score, the greater is the likelihood. Okay? The pathway can identify between 30 and 50% of patients who could avoid a biopsy. The average is 30%. So you should be achieving 30%. In your practice, you should be achieving 30%. Okay? You can and should be reducing the insignificant cancer detection rates. You should be able to do that. In other words, your active surveillance rates will go down. Your prostatectomies for Gleason 3+3 will be going down. And the interesting thing is, the fact that imaging and image-directed biopsies are now in the guidelines means that there is a much more greater acceptance by urologists, particularly in Europe. Thank you very much.